Welcome back to the Barbell Medicine Podcast, where we bring modern medicine to strength and conditioning and strength and conditioning to modern medicine. This is another episode of The Rundown, where we weigh in on the latest in medicine, fitness, nutrition, and sports. This week, we're diving into the latest science and breaking news across strength, longevity, and policy. And first up, we're going to take a closer look at the deadlift, a lift that we know and love. But specifically, we're going to talk about the heaviest deadlifts ever done in a meet, and what historical powerlifting data truly says about the sumo versus conventional deadlift debate. Then we're going to flip the script on public health. First up, new research came out comparing the efficiency of vigorous physical activity to moderate and light physical activity for reducing the risk of multiple medical conditions. Then a new consensus statement was published on exercise intensity definitions that, to my mind, increases confusion about exercise intensity definitions. Plus, we'll cover the future of anti-obesity medications, looking at some new data on Semaglutide and how it may actually preserve muscle during weight loss, and a new controversial mandate in China requiring influencers to be certified experts. And also, we're going to talk about lead in protein powder. All that and more packed into this show on the Barbell Medicine Podcast. But first, I do have to introduce the second most handsome doctor in North America, Dr. Austin Baraki. What's going on, man?
Hey, doing all right. Squeezed in some training this morning. Deadlifted.
I saw that you deadlifted 600.
Yes.
Yeah. But it's a moderate sumo, so it's not real sumo.
True.
Yeah.
The deadlift is slowly coming back. Not obviously where I've been in the past, but now I can run and do a lot of other things that I was not able to do as effectively before. So I'll take it.
Is the moderate sumo stance really like harm reduction? Like you know what I'm saying? If you went full sumo, like toes out to the plate, like Johnny Candido dropping the plate on his toe at IPF Worlds in like 2017. If you go narrower, it's not really sumo.
Many years ago, when I first started dabbling with sumo, I did give myself a nasty case of adductor and high hamstring kind of tendinopathy, and I think I was just quite strong on conventional, and I was like, oh, I can pick this up, but my groin was not ready for it, and so I think that was why I transitioned to the moderate, and it kind of stuck. So. Yeah. Is what it is. But
when I first started lifting, I didn't know that a conventional deadlift existed. Like, you just looked up how to deadlift online, and all it was Dave Tate's Deep Squatter website at the time, and it's all just sumo. So I just thought that's how you deadlifted.
Sure.
As it turns out, I worked up to 545, I think, in my first year, which was whatever. Imagine how good it would have been if I figured out how to conventional deadlift early on. That's an extra year of training history.
Probably would have been about the same.
No, would have completely changed my trajectory. Would have completely changed my trajectory. And anyway, all right. Well, let's get right into this because we do have a lot to discuss. First up, we're talking about the world of strength records. So you sent me this video of Kyle Curvey deadlifting 420 kilograms. That's 924 pounds. Previously, we've talked about like different strongman records or whatever, but the important factor here is that this was done on a stiff bar. And if you're not a powerlifter or barbell connoisseur, let me just explain this to you. In powerlifting, they traditionally use a power bar for the squat and the bench press in most federations. Some federations will use that same barbell for the deadlift. So like USAPL and IPF, they'll use the same barbell for all three lifts. And other federations like the USPA, WRPF, ABS, et cetera, will use a deadlift bar. Now, the differences between these two bars are there's multiple. First, the stiff bar is 29 millimeters in diameter and 7 foot long. Okay, so compared to the deadlift bar, which is 27 millimeters in diameter, where you grab the bar, and it's 7.5 feet long at minimum. Some of them are even longer than that. It makes the bar whippier, deflect more. Most people report that they can lift more on a deadlift bar. And we're going to kind of talk about that and also compare these different records. The other thing is, and I don't know how much people confound, like, oh, the deadlift bar and it being whippier makes it easier for me to deadlift more weight versus just the grip itself because it is smaller. So anyway, you sent me this deadlift, Kyle Curvey deadlifting 924 pounds on a stiff bar. Oh, by the way, beltless.
Yeah, just one of the most impressive feats of strength for anyone who has experienced deadlifting in this fashion. I think we'll recognize that.
It got me thinking. I was like, that might be the heaviest deadlift ever done on a stiff bar. Now, Jesus Oliveras, I believe, has done this in training as well, 420 as well, which displays. No, but then I compared this to what has happened in competition. And yeah, in the IPF, which is and their affiliates, so like Powerlifting America in the United States, they're effectively the only powerlifting federation, but the largest one that uses a stiff bar for the deadlifts. So them and the USAPL, they formerly were affiliated. The heaviest deadlift ever done in either of those federations is 411 kilos. So basically you sent me a casual video of a dude 2 weeks out from a meet deadlifting 9 kilos more than the heaviest deadlift ever done on this particular type of equipment. Now, obviously, this guy didn't do a full meet. He didn't do squats and bench press beforehand, untested, whatever, but still.
420. It's a feat. Yeah.
Yeah.
So incomprehensible, even for folks like us who are maybe closer than the average person might be to accomplishing something like that, but still just not even anywhere in the same league.
Yeah. The top 5 deadlifts on a stiff bar for all time range from 400 kilos to 411 kilos. So everything's clustered at the top. And oh, by the way, 4 out of 5 of those were conventional. Only one was sumo. Mm-hmm. So just shout out to conventional deadlifts. Now you compare this to the top 5 deadlifts of all time, irrespective of drug testing, irrespective of equipment, and things get a little different. So the top deadlift of all time is 487.5 kilos, which is 1,074 pounds by Danny Grigsby in 2022. That was done sumo, and it is on a deadlift bar, actually a kabuki bar, as I recall, which is even more specialized equipment. So I didn't want to, belabor the point on equipment differences and drug testing and weigh-ins, 24-hour weigh-ins in the WRPF and USPA versus IPF is 2-hour weigh-ins. But I did want to kind of get your take on this. If the heaviest deadlift ever done in a meet with a deadlift bar is 487.5 kilos, and the heaviest deadlift ever done on a stiff bar is 420 kilos, even though it wasn't done in a meet, and so that delta is 67.5 kilos. That seems like a lot as far as the difference goes, right, between a stiff bar and a deadlift bar. Does that match your expectations as far as what people, how different somebody's deadlift would be if they trained on a deadlift bar versus a stiff bar? And what sort of difference does it make outside of the deadlift?
I think the challenging aspect of trying to come up with an answer here is that the variables that we're looking at are not just the bar, but also the different people competing in and executing these lifts. And so obviously there's the variable of different people having different kind of mechanical advantages and disadvantages, leverages, proportions, training histories, environments, things like that. It's not just the same person on one or the other. Even if you did have the same person on one versus the other, there's still going to be some element of, well, are they a little bit better trained at one versus the other? I have a decent amount of experience training both conventional and sumo simultaneously with relatively equal emphasis for many years. And perhaps unsurprisingly, they ended up being in a similar place. And this was all on stiff bar type performances. They were maybe ended up being about 15, 20 kilos difference at my level of performance. And so rather than looking at it in terms of absolute kilos, I think if you look at it as a percentage, right? So say 60 kilos out of about a 400 kilo overall deadlift, whatever percentage that ends up being, probably so let's call it, I don't know, maybe 10, and somewhere between 5 to 15% is probably a reasonable range of variation to expect between these two lifts, depending on the person, their training history, and their relative advantages and disadvantages. That's kind of my take. I do suspect that there are probably some people who may still, have a relatively equal or may even perform better despite consistently attempting to train sumo for whatever reason. That might include you as somebody who's particularly, I would say, a little more awkward on the sumo than conventional. But for those who are maybe of more average, proportions or advantages, then it might actually be relatively similar within maybe 5%, 10%, I think is a reasonable expectation in my mind. I don't know. What do you think?
Do you think that's between sumo and conventional or just stiff bar versus deadlift bar?
Actually, kind of both, to be honest. Yeah. The open question would be, well, do these kind of stack? Do they augment on one another, or because again, it's just you're throwing multiple variables in the mix on top of people who are variable inherently between them. So it gets pretty messy. But
yeah. My personal experience is that between a deadlift bar and a stiff bar, I have almost no difference in my top pulls. I mean, at meets, I think my best with a stiff bar is only 320 kilos, 705, and then my best with the deadlift bar is 332.5 in a meet. in training, they're more similar, maybe 10 pounds apart. And I could easily chalk that difference up to like, I didn't have as much oatmeal, in the morning.
Sure.
something unrelated, really. So I personally don't see a big difference between a deadlift bar and a stiff bar. And I think that those who do see a big difference between the two, either there's some sort of anthropometric advantage that they get with the greater deflection or whip of the deadlift bar, or it's a grip related thing that's really being captured rather than like the actual bar itself. I have a hunch, but I can't prove it, that the sumo deadlift responds maybe a little more favorably to switching to a deadlift bar. But again, I can't prove that. It's just more just on vibes. But here's the more important thing, right? So let's just say that there's a range between 5 to 15%, the difference between a stiff bar and a deadlift bar, sumo and conventional. It provided both are reasonably either both untrained or both like relatively well trained. What are the differences outside of the deadlift and outside of performance between, with this weight delta? And I think that ultimately there's none. Basically, I think that any sort of advantage you have in the amount of weight that you can lift with a very specific style of a lift is ultimately those benefits are concentrated on that lift, right? So this goes back to like the low bar versus high bar, comparison. People are like, oh, you can deadlift or squat more weight with the low bar. And it's like, well, that may be true for a lot of people, but it doesn't make your legs any stronger outside of the squat compared to training the high bar squat or a front squat or a safety squat bar squat, whatever. It's just very specific to the demands of the exercise that you're talking about. And so it doesn't mean you can leg press more weight, doesn't mean you can jump higher, doesn't mean you can run faster. And so ultimately, I think that stylistic preferences is what's going to predominate here. And I don't know that the absolute difference in weight actually matters outside of the competition setting, in which case you should adopt whatever style allows you to lift more weight because that's the sport.
Yeah, I'm inclined to agree with that part.
Okay.
Sure.
The last little nudge here, the thing here, and again, it's just more nerding out on powerlifting. I realize that only a few people care, but they happen to be concentrated in our audience. Sumo versus deadlift, or the conventional deadlift, there are people out there that have said and continue to say that, look, everybody, or most people, in fact, if they're taking a more reasonable approach or stance on this, they'll lift more weight if they do it sumo. They just need to practice and whatever. They're not saying that sumo is easier than conventional. They're just saying there's more mechanical advantage. And so if you want to be the best powerlifter you should do sumo. But then when you look at the actual data here and the data that we're using, I tried to control for other variables like weigh-in times, drug testing, et cetera. So I just used the top 100 raw deadlifts in the IPF, which is drug tested, 2-hour weigh-in, stiff bar, et cetera. Top 100 for men, top 100 for women. 52% of men pulled sumo, 48% of these top 100 were conventional, and then in women it was 65% sumo and 35% were conventional. There's some distribution differences, lightweight, middleweight, heavyweight, but yeah, ultimately to me, this isn't like a slam dunk. Like everyone should pull sumo because again, the top 100 deadlifts. By definition, you're capturing the pointy end of the spear here. Mm-hmm. You'd think they would have figured this out.
Yeah.
Like if there was a different squat pattern that I could adopt that's going to turn me into a world record squatter, I would have figured it out. I would have tried it. I've been trying. I just can't do it. So I don't know. Do you think these people all just need a coach that knows that the sumo deadlift exists, or do you think that maybe it's just really more of an anthropometry, and personal choice here?
I think that with sufficient time in a sport, and especially or ideally if you do have some competent coaching guidance, then over time you do end up kind of dabbling and experimenting with different things, even if you just use one or the other variation as a supplemental movement for part of your training or during an off season or something. And then you might find, oh, this actually feels maybe better in this way, or I have a knack for it, or it's getting stronger quicker than I expected, or whatever the case is. And so, it's not that so many of these things you can't necessarily predict up front when somebody is just getting into this sport, or really any sport, but rather it is the process of training over time that tends to reveal a lot of these things. The same thing happened. Like when I started swimming, as a kid, I was never going to be able to predict what strokes I was going to be better or worse at, what distances I was going to be better or worse at, or what my eventual best performances were, likely to end up being. Rather, it took a long time training all the different strokes, training and racing all the different distances before I was like, oh boy, that race was miserable. I'm never really wanting to do that again. Versus this other one, it's like, man, I'm actually doing pretty well in this. I'm enjoying it. I'm racing well. I'm placing well, etc. And so these kind of patterns and preferences and things like that emerge over time. And it doesn't mean that you end up doing those things to the exclusion of everything else. It's just like this constant long-term iterative process of experimenting. That's the same way how I discovered like, oh, I can reverse grip bench and I actually enjoy it. And it got super strong. It got within 10% of my best regular grip bench press. That was just trying it and seeing what happened and giving it a chance. And so I do think that there's some value in that. And a lot of people will end up kind of, these patterns will emerge over time kind of organically if you're doing it yourself or under the guidance of a coach who is kind of competent in this space.
Yeah. The job of a coach, to my mind, with respect to like exercise, technique or style, and like programming, at least twofold. Thing one is the coach is trying to maximize the training load that they can that a person can complete in a given training week, training block, or whatever. Two biggest bottlenecks are going to be time and physiological tolerance. And so a coach's job is to like, well, how do we fit all this in, right? So that's job one. Job two, with respect to technique, is sort of like a shaman, or like your guide to the sorting hat. You're basically trying to sample a lot of different, not only styles, but different, slightly different, assistance exercises, supplemental exercises to try to find this sort of key that unlocks the individual, right? It's the same thing with like a coach in sports, or maybe like a program director that's like, oh, look, you play football, but have you considered running track? Have you considered, lacrosse, rugby, whatever? And so you can identify where people thrive or how they can be kind of unlocked to thrive. I mean, that's the job. That's the job of a coach. Cheerleading is fun too. I like to cheer for my clients, but ultimately my responsibilities are a little bit more with respect to training load and figuring out what's the best way for them to move right now. And yeah, as you mentioned, it does change over time. But I thought this was interesting. Maybe our listenership will agree or disagree. They've all clicked off already. They're like, they're not listening to this. All right, next topic: new intensity science. So this paper came out talking about the comparison between vigorous physical activity and moderate intensity physical activity. Previously, there was this assumption that 1 minute of vigorous physical activity, this is just cardio, vigorous cardio, was equivalent to 2 minutes of moderate cardio. Because this is effectively in the public health guidelines for minimum physical activity recommendations. So you should do at least 150 minutes of moderate to vigorous cardio per week, or you should do at least 75 minutes of vigorous intensity cardio per week. But this new data set or analysis of an existing data set kind of calls that into question. So what they did is they took accelerometer data. So basically it's just a wearable that measures when somebody starts to move, right? And actually they used this interesting machine learning program that categorized it as a particular type of activity, which I thought was interesting. Rather than just counting, they normally count its counts of like steps and like displacement. This was a little more refined than that. So anyway, they used that sort of data to analyze 73,485 adults over about 8 years on average. And it quantified the amount of moderate intensity cardio or light intensity cardio, really it's physical activity, because I don't think they made sure this was all just straight up cardio. That amount of conditioning that would achieve the same amount of risk reduction for various diseases as 1 minute of vigorous intensity physical activity. And so they measured this for all-cause mortality, mortality related to heart disease, major adverse cardiac events, type 2 diabetes, cancer, etc. So what they came up with was for all-cause mortality, that 1 minute of vigorous intensity physical activity was equal to 4 minutes of moderate intensity physical activity. For type 2 diabetes, it was 1 to 9, right? And for cancer-related mortality, it's 1 to 3.5. And for heart, cardiovascular disease related mortality, it's 1 to 7.8. All of this is saying, like, look, actually, vigorous intensity physical activity seems to be way more efficient and protective than moderate intensity. The ratios for vigorous compared to light physical activities, they're even crazier. I think it was like 1 to 138 for all-cause mortality. So the first question is, why does this massive difference between the assumed relationship between vigorous and moderate intensity physical activity compared to the observed? Why is there this massive disconnect? Why do you think that is?
I don't know. This is straight up. I'm happy to say when I don't know things, and this is one of those occasions. I found this paper, this discussion topic, interesting because you're right. It is so embedded and ingrained in the general public health and physical activity guidelines to either do the certain amount of vigorous or essentially twice the amount of moderate or some combination to achieve a similar overall energy expenditure throughout the week. It does feel a little bit too neat and tidy and simplistic for that to, be completely equal in all ways. I do wonder, though, if even this data ends up taking us in in a slightly erroneous direction to where moderate or lower intensity activity ends up getting almost neglected in some way or deprioritized, where people might say, oh, if I just do a minute, then, I'm good for the rest of the day or something like that, because I think that, we've talked about before how in the context of exercise prescription or when you're programming for someone, the intensity of exercise relates somewhat powerfully to the type of adaptations that people get, because there are unique physiologic demands to higher intensity activity compared with lower intensity activity. This is the same argument that has come up in recent years when zone 2 exercise got super popular, and it was seemingly almost to the exclusion of a lot of other things where there were all these unique benefits to it. And it's like, yeah, it has unique benefits, just like doing any exercise has unique benefits from that exercise, but that doesn't mean they're so unique that they are necessarily superior to those that you can get from exposure to other intensities and types and varieties and durations of activity as well. And so I have some reluctance to jump fully on board with, I think, what some might take to be the implications of these data and say, oh, well, low, moderate or low intensity are out, high intensity is in, I'm back on the HIIT train, I'm just going to lift and then push a few hard intervals and then I'll be good. And it's like, well, you're going to be way better off than a lot of other folks. You're going to be way, way better off than any patient that I tend to see in the hospitalized setting, for sure. But are you getting all the potential benefits that you might actually have from exercise that include those that we can derive from moderate or lower intensity activity? Because the only things that you can determine from these data with confidence is the outcomes that they specifically measured. There's a whole bunch of things that they, health outcomes that weren't necessarily measured that may also be important or valuable or not captured across an 8-year time span in this cohort of people or something like that. So I don't have a great explanation for why there's this huge difference. I wonder if you have some thoughts there, but I'm more so found the observation interesting, but I'm also cautious about how aggressively I want to alter or narrow my prescriptions based on the findings that were described here.
Well, I actually do have a theory here, so bear with me on this.
Okay.
Because even though this machine learning that they use to basically, again, use the wearable to ascertain when somebody started movement and like the intensity of that movement, so like how much do they accelerate, for example, they still ended up using METs, so metabolic equivalents, to ultimately categorize the activity as, light physical activity, moderate, or vigorous. And METs, we've explained a number of times why we hate METs, but the main thing is that it attempts to be this one size fits all measurement. Like one MET is equal to 3.5 milliliters of oxygen per kilo per minute. It's basically something used for research to try to estimate energy expenditure of an activity. And there's a metabolic compendium, so you can see, like, on average, for a person who maybe weighs 70 kilos and is of average level fitness, this is how much each activity costs energy wise. But it varies so much between individuals, like what a particular activity at a particular intensity, the amount of energy that they use. Like, it's just not really something you can use on an individual basis. And so my theory here is that this is really just an artifact of using METs. once you basically, if a person is moving fast enough or at a level where the watch, the wearable says, oh, this is vigorous, then effectively they're expending enough energy for it to actually count as exercise. It doesn't mean that it's actually like high intensity or sprint intensity. It just means that, hey, it's not actually, it is actually exercise. And so I suspect that, at least my theory is that if you just fraction all activity into vigorous, the vigorous category based on METs, then you're eliminating any of the portion of exercise that's not actually exercise. Just a problem with the way it's measured. That's my theory anyway.
It's almost like a sensitivity specificity thing. You're much more specific to capturing exercise, and whereas at lower intensities, at least as captured by accelerometry, you're saying that you're more likely to be capturing just maybe routine activities of daily living, for example, that might be captured on accelerometer, but not exercise. And those we don't necessarily think confer the same degree of benefit, or at least you require a lot higher doses of routine activities of daily living to get there.
Yeah. Well, like walking, for example, the self-selected gait speed for most folks, how fast they walk, is somewhere between like 3.2 miles an hour or whatever. Mm-hmm. And now for a person who's relatively fit, going out and walking that pace or even more briskly than that, probably doesn't even register as exercise, right? It's physical activity, to be clear, but it's not exercise insofar as how people classically think about it. Like, oh, is this going to improve my cardiorespiratory fitness, for example? Like, probably not for a person who's in reasonably decent shape. On the other hand, if a person had like COPD, walking at that pace is a high intensity activity for them, right? And so, but if you just use the MET score to classify things as, oh, this was moderate intensity, vigorous intensity, whatever, you're just going to miss a lot here. That's my thought. It seems plausible, but you'd need some verification data here.
Totally.
I just don't like METs. Like I don't know what else to say. I think it was a choice to use for public health like communication, like in the physical activity guidelines. Mm-hmm. But it's not like medical professionals or even fitness professionals know what a MET is. And then even if you do, how do you explain that to people? You're like, you need 150 minutes at least of cardio per week, and it needs to be there at moderate to vigorous intensity. And they're like, well, what is moderate to vigorous intensity? You're like, oh, like 4 to 6 METs. And they're like, well, what's a MET? And you're like, well, it's a measure of energy expenditure. And they're like, well, how do I rate that? And you're like, I don't know, actually. So
yeah, I agree. Really frustrating to, attempt to use those guidelines, at least as written, to deliver that type of prescription. But, there are a lot of other ways. I've lectured, when teaching, groups of students or trainees on this, and we've talked about various ways to communicate exercise intensity, be it subjective metrics, RPE, talk test, things like that, at least as it relates to cardiorespiratory or aerobic activity as a potentially more useful or understandable tool. Kind of like when it comes to nutrition counseling and like how do we advise people on portion sizes, and you can use like your palm method and various other things that are much more practically useful compared with prescribing either percentages of total energy intake or something like that are not intuitive for people.
Yeah. So my main takeaway from this is that it is that exercise needs to be hard enough to count as exercise in order for it to work. That's going to be individualized based on the person's fitness, right? Obviously, and their capabilities. And so what I would use rather than METs or like, some sort of similar rating that people can't really either do on the fly, like RPE somebody could do, or even just heart rate recommendations. Because if you don't have a heart rate monitor or if you have some condition or whatever, people vary. Just use the talk test, as you alluded to. The talk test, super easy. So effectively, you should only be able to speak a few words before having to take a breath. Most of the time, the recommendation is to recite something like the Pledge of Allegiance. And if you can get all the way through it without having to take a breath in between, you're not exercising hard enough based on the talk test. There's a counting talk test as well. That's a similar thing. You count from 0 all the way up to as high as you can go before you have to take a breath at rest, and you compare that to when you're exercising. And when you get to the halfway point, before you take your first breath, that's a positive test, which basically means, oh, you're probably around this ventilatory threshold 1, which signifies, yeah, you're probably getting into definitively this is exercise. And to me, that's a more practically applicable way to measure, like, am I exercising or is this physical activity? The last thing I'll say here, I'm not hating on walking or light intensity physical activity or just generally being active. I think all that stuff is useful. it certainly is beneficial, just being more active, generally speaking. It displaces sedentary behavior, displaces other behaviors, like eating, for example, for some folks. But I don't know that it actually contributes to fitness that much unless it's at the correct intensity to drive those adaptations. Fortunately, the intensity range that works is quite wide. You just have to get to that threshold, which is probably around 60% of your max heart rate on the low end. And like, I don't know that Mets captures that well.
I think that's a reasonable argument. My only counter, I guess, not based on tons of evidence or data, but the low level activity, I think, can plausibly contribute to fitness, depending, of course, on how you're testing fitness. But it's just that the dose in terms of volume has to be massive.
Yeah.
Right. And so, I mean, historically, if you go back through the history of endurance training, there are people in the olden days who their main training for marathon was hours and hours and hours and hours and hours of walking.
Yeah.
Right. Mm-hmm. And so it is possible to build fitness through that way, through those methods. But that's kind of the scale knob is volume versus intensity, which is obviously debates that's been going on forever. And we can stand to benefit from both.
A little bit of both. Mm-hmm. Yeah. There you go. Well, overall, I think maybe the bigger takeaway outside of all of that is, hey, we just need some better definitions and ways to communicate exercise intensity. So fortunately, the American College of Sports Medicine just put out a new consensus statement on definitions for exercise intensity. They basically cited that there's some inconsistency with jargon, with terms like light, moderate, and vigorous are used in public health, but sometimes these are interchanged with low, moderate, and high, and the definitions for both are not always the same, and cutoffs for both. So, for example, light physical activity is said to be less than 3 metabolic equivalents, whereas low-intensity cardio is often said to be less than 60% of max heart rate, and sometimes these things don't match up. So, like, where does exercise start? How do you communicate this? So, this ambiguity is not only a problem for public health, but also in research, right? Because you'll see a paper that says high-intensity cardio works better than low-intensity. You're like, well, what does that mean? It's not immediately understood. And so then you have to go into the methods and you're like, well, why did you define it this way? People just kind of choose their own adventure here. So they came out with a new set of recommendations. First off, the intensity domains, there's 5 of them, according to this new consensus statement: very low, low, moderate, high, and very high. And so what they tried to do was apply this to both cardio and resistance training. So for cardio, they said a very low, well, look, we admit there's no current measure for this, so just go with God. We don't know. For low intensity cardio, they say this has to be below the first metabolic threshold. We'll get to this metabolic threshold thing here in a second. For moderate intensity cardio, it's between the first and second metabolic thresholds. Again, we'll come back to the metabolic threshold. For high intensity cardio, it's between your second metabolic threshold and maximal work rate. So it's basically like you're exercising at maximum intensity, but you can sustain it for a little bit. So not a sprint, because you can't sustain that. And then very high intensity cardio is above your maximum work rate. So it'd be like a sprint, basically. And then they tie this to resistance training, where very low intensity resistance training is greater than 8 repetitions in reserve. Low intensity resistance training is between 7 to 8 repetitions in reserve. Moderate intensity resistance training is between 4 to 6 reps in reserve. High intensity resistance training is between 2 to 3 repetitions in reserve. And then very high intensity is less than 2 repetitions in reserve. On the one hand, this does seem to unify everything. It is neat and tidy, but I got some problems with this.
Let's go.
First, the resistance training thing is interesting because, like, wow, this is almost the first time that this has ever tried to be like tied together. But without a rep range or like some sort of measurement of relative intensity, I think it lacks specificity. So, for example, somebody could do a set of 30 with, RIR less than 2, but that's not very high intensity. It's hard, but it's just not heavy enough, right? And I go back to that Schoenfeld meta-analysis. It's a seminal paper basically showing that strength improvements are greater with higher intensity weights, higher intensity loads. And the cut point here is like 65% of a 1 rep max. And so if the assumption is with the scale that nobody's doing sets greater than like 15 reps or 20 reps, then sure, it holds, right? But that's not always the case. And I think that wasn't anywhere in the paper either.
Yeah, failing to differentiate proximity to failure from intensity as actually different concepts that get conflated a ton by people because they envision even a low intensity set, so a relatively light weight. But if you take it close to failure, man, if you look at the person's face on those last few reps, it looks super intense. And so intensity can be just a confusing term when these two concepts that are actually distinct are conflated because they lead to different outcomes and different adaptations.
Yeah. So I don't have a suggestion for this other than like you would probably want to say, look, this is really for sets less than 20 reps or less. Like that's the cap, right? Or a 15 rep max load or more, or 60% of 1RM. But ultimately, like I think that's fine for a research setting, maybe not great for public health. I don't know. No one asked me. Then this concept of a metabolic threshold. So if you start your consensus statement out saying, look, definitions and words and nomenclature, these are all highly variable in the exercise science world, and we need to come up with a consensus. And then you introduce a new term, metabolic threshold. It's not really new because the concept has been discussed for decades and decades, but just no one uses this word, this phrase. This term is used to describe an exercise intensity that results in an apparent change in metabolism. That's why it's called a metabolic threshold. So changes in oxygen uptake, carbon dioxide production, ventilation, blood lactate levels, so on and so forth. So it from that definition standpoint seems fine, but like what are we really talking about for metabolic threshold 1, metabolic threshold 2? They're equating metabolic threshold 1 with the first lactate threshold, which represents the initial increase in blood lactate above resting levels, also called the aerobic threshold or ventilatory threshold 1. Okay. And then the second metabolic threshold is approximately the second lactate threshold. This is where lactate accumulation rapidly outpaces the body's ability to clear it, also called the anaerobic threshold, the respiratory compensation point, or ventilatory threshold 2. These things don't all line up perfectly, but they're close enough for this type of work. So I don't know. Maybe I'm just being a jerk, like about and pedantic and whatever, but like I'm just annoyed that they picked metabolic threshold. Like, why introduce a new term that's not commonly used?
Yeah, it is, I guess, maybe helpfully or appropriately drawing a ton of attention, I don't know, away from lactate. I don't know if that's something that we feel was necessary, but there's some potential benefits to making people worry about lactate a little bit less, although there's certainly, validity to it as a concept on its own in exercise physiology and metabolism. And so making it a little bit more of a general thing, I don't know, we're just kind of spitballing here, but is what it is. I doubt that this is going to have any meaningful impact on anything in the near or medium term.
Well, that's the thing. Like so with if this new thing is adopted, right? These new intensity domains are adopted. Like in the research space, maybe that's helpful. But then when you look back at historical data, then you have to kind of like reverse engineer what they did. And hopefully all these things were reported. So I don't know that this is helpful, but maybe it'll be helpful 50 years from now if this is widely adopted and like we have a better sense of things outside of maybe the concerns about resistance training that we talked about. But then now, if you're trying to compare like high intensity or very high intensity cardio to moderate or low intensity cardio based on these 5 intensity domains, do you have to measure their blood lactate to like make sure they're above a metabolic threshold?
Sure. Yeah.
I don't know. So, okay. So what you're listening to this, if you're listening to this podcast and you're like, what the heck? How does this affect me? It doesn't. Just broadly speaking, it doesn't. I think, with our previous discussion that where vigorous intensity physical activity did better than moderate intensity physical activity as measured by METs, and the confusion around maybe these metabolic thresholds. And you're like, well, look, how hard should my cardio be? Just like, can you tell me? Well, we want the majority of it to be right around metabolic threshold 1. That we would call that zone 2. All right. And if you're exercising at that level of intensity, where again, you're becoming breathless when you try to say a phrase like the Pledge of Allegiance, for example, it's hard enough, but it's not so hard where you can only do a little bit of it, or I start worrying about fatigue. Now, the main concern there is if you're actually doing a ton of conditioning throughout the week, like more than 3 hours or so in a given week. If you're doing less than that, I honestly don't care. The only thing I would really care if someone's doing less than 3 hours and they're like, oh, Jordan said I could just do as high intensity as I want. I'm just doing all sprints. I'm like, well, that's probably not a good idea either, just from a fatigue standpoint. So I do think that the talk test making sure you're kind of around that metabolic threshold 1, which we can identify with the talk test. That seems reasonable. If you're at or slightly above that, I feel fine. And if you want to do some sprints on top of that, that's all well and good. It really starts to matter how you distribute your intensity far more when you're doing an actual large volume of conditioning. Does that seem reasonable to you?
Yeah, I think the only other caveat that I would add is that your level of training advancement has a significant impact on how these things are distributed. And it's kind of baked into your advice there, to where you said that the way you distribute it matters more when you're doing high volumes. And most people are only ever doing high volumes when they're at later stages of advancement, but that might not always be the case. I think that when you are newer to training, you can often get away with dipping into higher intensity more often. And actually, that is the case for both aerobic and strength training as well. We see people who, push their, rep max effort sets multiple times a week in beginner programs all the time, where you're just adding weight to the bar all the time. And you can get away with it for a bit of time, but that's not even a medium to longer term training strategy to be able to do that. So the more your level of training advancement progresses, you definitely need to distribute your intensity much more differently. And so, I tend to put fewer limits and recommendations and things like that in. In other words, giving beginners more options to explore and experiment. And then if somebody gets motivated, if they, start to have specific goals crystallize as they get more advanced and they need to be able to do more, then definitely those details become more and more significant over time. But a lot of people could do with trying a bit harder a lot of the time.
Yeah, Dr. Derek Miles has said something that I do think happens to be true, that generally speaking, when people are trying to do this, moderate intensity, steady state stuff, zone 2, whatever, it's usually not easy enough. And then when they're doing sprints or the high intensity stuff, it's usually not high intensity enough.
Yes. Yeah.
I think that it sounds truthy anyway.
Sure. Yeah.
Sounds truthy. Anyway, this is an open access paper, so all these resources are linked in the show notes below. You guys can read it. And if you disagree with me vehemently and you want to argue about it on the internet, I'll do it. I will. All right. Now we're going to move on to some medical and wellness updates. Hey, did you hear about this? New Nobel Prize was awarded to Shimon Sakaguchi, Mary Brunknow, and Fred Ramsdell for their work on the immune system's, quote, security guards, regulatory T cells. I know you're a big regulatory T cell guy, but it wasn't just the discovery of that, but this genetic switch, which is FOXP3, that controls at least some of the regulatory T cell activity. Now, regulatory T cells are an immune system cell, and this FOXP3 genetic switch is heavily involved in a lot of autoimmune diseases. So in 1995, Shimon Sakaguchi discovered this previously unknown class of immune cells that usually protect the body from autoimmune diseases. These are named regulatory T cells. In 2001, Mary Brunknow and Fred Ramsdell identified a gene that they called FOXP3, and they demonstrated that mutations in this gene are the cause of serious autoimmune disease known as IPEX syndrome. Have you ever heard of this?
I have not heard of IPEX syndrome. I mean, when you go down the road of autoimmunity and autoinflammatory diseases and things like that, this is an insanely complex space. A lot of genetic and molecular signaling and cytokine-mediated things that is complex even for subspecialists in that field.
Yeah, look, if you're a rheumatologist and it's actually IPEX syndrome, my apologies. I'm unsure. So it's an acronym. It stands for immune dysregulation, polyendocrinopathy, enteropathy, and X-linked syndrome. So IPEX. IPEX seems
Sure.
reasonable. So this is caused by mutations in that FOXP3 gene, which is located on the X chromosome, and it makes the gene non-functional. So under normal conditions, the functional gene helps regulatory T cells not attack our own body. But if it's not functioning, the system runs amok. So this leads to early onset type 1 diabetes, thyroid disease, malabsorption, failure to thrive. Yeah, usually caught pretty early, and some severe long-term problems here. In 2003, Sakaguchi connected the findings of, previously discovered regulatory T cells and this FOXP3 gene. He connected these findings, showing that the FOXP3 gene governs the development and function of regulatory T cells. All right, so they won this Nobel Prize. What's the relevance? You're listening to the Barbell Medicine Podcast. What the heck? Is just like a Nobel Prize, thing? Well, these FOXP3 expressing T cells are also involved in recruiting satellite cells for muscle tissue generation. So their function is obviously impaired when people have this non-functioning genetic mutation. and it's involved in inflammatory myopathies like poly and dermatomyositis, which they have less satellite cell recruitment. So that there's a failure to put the brakes on the immune system's repair process. You get uncontrolled inflammation at the level of the muscle. You get fiber necrosis of the muscle fibers. You get muscular atrophy and fibrotic replacement of muscle fibers. And so, yeah, weakness and such can appear. Now, I went down the rabbit hole here, and I know neither of us are rheumatologists and whatever. And so there is a link between the amount of disease control and the amount of fiber necrosis and weakness that's seen here, which is kind of what you would expect. But I thought that was interesting. There's some muscle biopsy studies where they actually look at the amount of satellite cell and myonuclei per muscle fiber, and they can kind of correlate that with the level of disease severity, which I thought was interesting. So congrats on the Nobel Prize. Now we need to do the final step. Figure out how to fix this thing. So
yeah, it's an interesting topic, and to your point, the immediate applicability to the audience is going to be limited here. But here's kind of another angle on this. There was another paper in the New England Journal that came out within the past week or two. It's not actually formally part of our outline or our topics for discussion today, but what they basically looked at was a large cohorts of patients who had been diagnosed with certain medical conditions, essentially clinically, meaning the patient had what looked like a prototypical syndrome that looked like maybe celiac disease or maybe looked like some other kind of known diagnosis. And they did further genetic analysis on these folks. And in a significant proportion of these patients, what they found was that they actually had distinct different genetic syndromes that led to that similar kind of overall clinical phenotype, or it looked like a condition, but it was actually a misdiagnosis of an underlying genetic syndrome that hadn't been recognized. Which I can totally, as a clinician, I can totally see how this happens. If a patient looks like they have a particular diagnosis, and I'm confident enough to rubber stamp that as their final diagnosis, I'm unlikely to go a ton further and do a bunch of advanced genetic testing, at least based on the standards of practice today and the technology that we have readily available to look for these types of underlying things. But recognizing that these things are possible has led to a lot of changes in how diseases are recognized and diagnosed and how they're associated. Even since we were in medical school and training, a lot of this stuff has evolved, and additionally leads to more disease-specific and more targeted therapies towards the specific genetics that a person, is manifesting. And this, in the most obvious example, is like targeted chemotherapy type drugs for certain types of cancers based on the specific genes that they're expressing. But following this, for me, is useful, even though I'm not a rheumatologist who's going to be routinely doing this type of advanced genetic testing, but I do see and diagnose polymyositis and dermatomyositis, and thinking about, is this just run-of-the-mill, that condition, or could it be part of one of these broader syndromes, for example? I'll give you one last example. Something else that came up for me recently with a patient, and this also reflects this evolution over time, is I had a guy in his 70s, and he had a history of atrial fibrillation, super common condition when I went through school and training. This was like, atrial fibrillation, it happens. We'll put you on a blood thinner, we'll control your heart rate, and that kind of is what it is. And then he also had some chronic back pain, and he ended up undergoing some imaging, and it showed some evidence of spinal stenosis. And in my mind, that was an immediate trigger of, oh, well, we have now increasingly recognized over the past decade or so that there's this other condition called amyloidosis that can lead to both atrial fibrillation and spinal stenosis. It can also lead to things like carpal tunnel syndrome. It can lead to tendon ruptures. It can lead to neuropathy. Can lead to a lot of other manifestations. And if you catch and diagnose that treatment early enough, we now actually have targeted treatments for this particular type of amyloidosis that can delay the progression and prevent you from developing advanced heart failure and needing pacemakers and all sorts of things in the long run. So whereas this guy a decade ago would have been like, yes, you have AFib, take these meds, you have spinal stenosis, go see this spine surgeon. Now I am guiding this evaluation for systemic amyloidosis, which hopefully rules it out completely. But if I catch it, will definitely alter the trajectory of this patient's life. And so that's why, for me, keeping up with this stuff as it evolves is actually super useful, because it does actually end up impacting practice at some point, even if the immediate clinical relevance, like the same year that they won the Nobel Prize, like I'm not going to be doing this gene testing. But if we find some implications or some treatments or some novel genetic syndromes that I can look for when a patient checks certain boxes, yeah, that changes how I do things, and that changes patients' lives.
It's very root cause of you.
There you go.
Yeah. All right. Moving on to semaglutide. Once again, talking about semaglutide GLP-1 agonists. So everybody knows that obesity is a major public health concern, although I believe the last 3 years were the first 3 consecutive years on record that we have that obesity rates have actually declined, which
winning.
There you go. So GLP-1 receptor agonists like semaglutide, so Ozempic, Wegovy, these have emerged as effective pharmacological treatments for weight management, demonstrating significant weight loss in clinical trials, often exceeding 15%. However, there has been limited data on these medications, particularly at the highest doses, on their impact on body composition, specifically muscle mass, muscle function, and the risk of developing sarcopenia. In fact, there's been a lot of kind of not only public discourse amongst lay people, like, oh, you're going to lose all your muscle mass, but even some professional discourse where very intelligent people whom I respect are like, the risk of sarcopenia from these drugs is incredibly high. So this was an interesting study. It's called the Semaglutide study. Great name. This was a prospective longitudinal trial conducted in France to investigate the effects of once-weekly semaglutide on body composition, lean mass, and muscle function over a year in adults with obesity and at least one related medical condition. So there's 106 patients here. 68% were women. The mean BMI was 46.3, so pretty significant. They all received semaglutide with a progressive dose escalation up to the max dose. Key measurements were taken at both 7 months and 12 months, including and baseline. So they got DEXA scan to look at like lean mass loss versus fat mass loss to assess body composition. They also did hand grip strength for muscle function and some other tests. Notably, 49%, so nearly half of the patient population, exhibited sarcopenia at baseline, which they assessed with the appendicular skeletal muscle mass test and hand grip strength. So those were the 2 measures, which is a reasonable definition for sarcopenia, although the European Working Group would be like, we could do better.
Need more functional assessment. Yeah.
Indeed. So the results. First, as expected, significant weight loss was observed, averaging about 10% at 7 months and 12.7% at month 12, which pretty good. That's kind of what we expect from semaglutide, generally speaking. 60% of the subjects achieved at least 10% of weight loss, and 26% of the patients achieved 15% weight loss or more. Lean mass decreased significantly in absolute terms during the first 7 months of treatment. The average amount of lean mass loss was 3 kilograms, which then stabilized and didn't decrease after that. To be clear, this is not just straight up skeletal muscle tissue. This is everything that's not fat mass. So this can be water, glycogen, certainly muscle tissue, but also other things, anything that's not fat. Based on the values provided in the article, they didn't actually report this, but I did some calculations here. The calculated proportion of fat mass loss to lean mass loss in the at 1 year, it was approximately 80% was fat mass and 20% was lean mass. Hand grip strength also improved at 7 months and continued to improve at the 12-month mark, despite not exercising.
Mm-hmm.
So, first question to you, is there some sort of preservation effect of GLP-1 receptor agonists on lean muscle mass? Because the predicted sort of proportion of fat to lean mass loss with like diet-only interventions is 75-25. Mm-hmm. Now, this isn't that different, but it's not zero either.
Yeah.
So, should we all be taking GLP-1 agonists to start preserving muscle mass or what?
Yeah, I have historically found the kind of hysteria around muscle loss with these agents to be really irritating and also short-sighted in a lot of different ways. So many of the health complications that are among the leading killers worldwide, namely cardiovascular disease, cancer, things like that, are more often related to the consequences of excess body fat and things like that than they are directly attributable to having insufficient muscle mass and muscle function. But even if we were to focus the lens a bit more on sarcopenia as a problem in itself, which, hey, both of us also, we have, we are quite concerned with that as well for a variety of reasons, recognizing that the assessment and measurement of it is complex. It is both muscle mass and, more importantly, muscle function actually has been shown to be the more important variable here. And additionally, we know that measuring muscle mass is complex depending on the tool, the instrument that you use to measure it. But also, when people have excess body fat, adiposity, there's also fat deposition within and around muscle fibers and all sorts of things like that, right? And so that can lead to certain measurement artifacts. And so you can have a situation where you are actually, while losing body fat, the overall maybe cross-sectional area of a muscle might be declining, but the muscle quality is improving. And muscle quality, which is the stronger variable related to muscle function, is what I care more about than what is the absolute just mass, or if I take a CT cross-sectional image and I just outline it and I measure the area. So muscle quality and muscle function are the things that I'm more concerned with. And so to the extent that I see that improving, I'm content. Now, we also know that it doesn't have to be one or the other with the use of medicines or the use of exercise. We see the best results, including people gaining and building muscle mass, muscle strength, muscle function while losing substantial amounts of weight on these medicines, if we can just get them to lift a little bit of weights here and there, which doesn't even have to be a full-on, 6-day-a-week powerlifting template. It could be, 2-3 times a week with a couple sets that are just hard enough. A beginner will respond to that. And so that's kind of my perspective on this. Is my interest in the overall muscle mass question, it has declined over time, I would say, and my interest and focus on muscle quality and muscle function has continued to increase, and that is more so my emphasis when I look at these types of results, or when I'm working with patients. What can we do?
Yeah, I think there's just it is a misunderstanding of the disproportionate risk at both ends of body composition. So what I mean by that is, at the higher end, where you're thinking that somebody has a lot of excess body fat, adipose tissue, effectively that becomes a much higher risk than the potential benefit of a lot of muscle mass. Mm-hmm. Individuals with obesity tend to carry more lean body mass than lean counterparts, just generally speaking, but they're not really absolved of the risk from excess body fat just because they're carrying extra muscle. So there's a kind of a misunderstanding on that side. And then with respect to GLP-1 agonists, anti-obesity medications at large, there's also a misunderstanding of like the risk of developing sarcopenia, because the thought is like, well, you lose any muscle mass, that's sarcopenia. Well, right. No, that's not what sarcopenia is, because it specifically requires a decrease in muscle function that is large enough to cause functional decline and a lot of other problems. And so at the lower end, which is way on the other side of the pole, the other side of this continuum, we're really talking about there's been such significant muscle loss that the person is now, they can't function, which is not what we see.
Not happening. Yeah.
It's not what we see. Like if because there was a concern with people with sarcopenic obesity. So they had already poor muscle function and they had obesity. And it's like, well, should these people be on GLP-1 agonists? And like, that's still a clinical question that's out there, right? Because you're worried like, well, they already have poor muscle function. And so the thought is if they lost additional muscle mass, that would reduce function further. But to my mind, that's mostly like a muscle training, muscle quality. Kind of thing, rather than like absolute amounts of muscle mass. Like they got muscle mass already, it just doesn't function very well. And so that's like an activity thing. So anyway, in this particular study, they actually did assess muscle function. Now, it was hand grip strength, and we've talked about hand grip strength for a while. But despite not exercising, at least they were not told to exercise. But most of these folks have tried to lose weight a number of times before, and some of them had been in previous trials. Their average BMI was 46.3. The idea that these folks had not been encouraged to exercise for their entire life seems unlikely. So unclear how many actually were exercising. They did not assess that. But there was an average increase of 4.1 kilograms at 12 months in hand grip strength performance. Now, this does exceed the minimal detectable change, which is 2.9 kilos. So it does appear to be real and not just like a statistical aberration, but it does not exceed the minimal clinically important difference for hand grip strength, which is estimated to be between 5 to 6.5 kilos. So I don't know. I don't have a good explanation for this, I guess is what I'm saying. I don't know that. And in fact, I don't think that excess body fat necessarily itself has a deleterious effect on muscle function, whereby losing body fat now like unlocks your muscles' ability to actually produce more force. If I had to like rationalize this, I'd say, well, look, if they hadn't done a hand grip strength test before, right, familiarization with the test could have led to some of this. And that's why it didn't exceed the minimal clinically important difference. It's basically like, oh, you figured out how to do a hand grip strength test better. And so that's part of the increase. But it is reassuring that at least these people their hand grip strength didn't go down.
100%. Yes.
Oh, cool. And so with the definition they use for sarcopenia, which is reduced grip strength coupled with reduced appendicular skeletal muscle mass, the sarcopenia rate, which started at 49%, was 33% at 12 months. And so, yeah, we can hem and haw about how they define sarcopenia and the, validity of a hand grip strength to monitor, muscle function over this time period. But like, I think it's time for some people to eat a little bit of crow.
I hope so. I don't know that they will, but
I don't think they will.
We can hope.
Yeah, we'll see. We'll see. All right. We've got two more topics here. We'll wrap this up. First off, and I know this is your favorite topic, we're talking politics, baby. So look, effective in October of 2025, this year, the Cyberspace Administration of China will require influencers who create content about sensitive topics, specifically medicine, law, education, or finance, to certify that they have formal training and expertise in those fields. They basically have 2 months to submit degrees, certifications, or verified credentials to demonstrate their expertise. And all content on these topics must clearly cite the sources used and specify whether it includes dramatizations or AI-generated elements. And it's actually the government, apparently, of China is putting a major onus on social networks like TikTok and some of the other ones that are used in that country to verify the influencers' credentials and remind their users of their own legal and scientific responsibilities regarding information dissemination. So they also are banning the advertising of medical services or products, including medications, supplements, or health foods. And they're ordering the removal of accounts using educational formats to promote products or impersonating professional identities. And so they're basically saying, look, if you're a social network, you got to train your algorithms to block this stuff. Also, if it includes sexualized content disguised as educational. Thoughts? Like, do you think this actually protects the public from misinformation, or is it setting a concerning precedent for government control over online discourse, like freedom of speech? Like, what do you think? Obviously, it's different countries, so they don't have the same.
Totally. Yeah. I mean, I don't love it. I think that there's some good, but mostly bad here, to be honest. China's level of control over everything in their society is, I think, pretty counter to a lot of the ways that we think and live in the States and the things that we value, not just in the States, but I guess in the West more broadly speaking, although there's some variation, say, between the US or Australia, EU, things like that. But with that said, banning advertising of medications, for example, like we're, I think, on the
pro
in the camp of, not preferring to see pharmaceutical advertising direct to consumer. Wish that would go away. But other things about this, requiring that these platforms verify communicators' degrees or certifications to be able to post things on the platform, I think that is A, quite onerous, B, also potentially problematic for a lot of ways in terms of what credentials count, which ones don't, who decides, from what institutions. Is that itself going to have some, unintended second order effects of obviously there's probably some level of control over that too, but like who can open an institution that then becomes accredited, or what credentials are allowed? Do they accept any sort of international, credential? Like it gets such like a complex web. And I don't think that is something that I would be in favor of requiring. I think I tend to lean more on the side of people being able to speak. You and I interact regularly with people on the internet who are fools and make all sorts of, inaccurate, non-educated, even in many cases, potentially harmful comments and things like that. I still don't know that I am likely to fall down on the side of, well, just because I, had the fortune and the resources and everything to go through this schooling, only I can speak about this this thing in any meaningful way. Because, man, I train junior doctors, I train medical students. Many of them, would I like for them to go out and start opining about things on the internet? It's like, no, they're also likely to say wrong things, particularly if they veer outside their scope of expertise. And so I think physicians and experts, they are more likely to be correct on a topic than a non-expert. that I'm in agreement with that
All right,
idea.
Tom Nichols.
But are they necessarily correct? Is it possible? Are they fallible? Also, very true. But their fallibility does not mean that we throw the relevance of expertise out the window and make it so that everyone's opinion is equal, because I don't actually think it is in most areas. But it's almost like this. I hesitate to use like some sort of bell curve, metaphor or something like that here, but some sort of like probability distribution of who is more likely to be correct. The person with more formalized education and training and expertise, but I wouldn't use those as legal arbiters or limits on who can speak about something. At least that's my take.
Yeah. I mean, I agree with, obviously, big shocker. I agree with what you said. I don't like the idea of the government telling me what to do. I mean, if this came to fruition in like the United States, for example. On the other hand, I do recognize that there is a huge misinformation problem, and I do think it needs to be addressed in some sort of like equitable yet effective and ideally evidence-based manner. I just don't know how to do it. I don't think it's this way, but I can understand why this was like done in that particular society. And there's likely cultural differences as far as like deference to actual experts. And so maybe that works in a culture like China, but I don't think it would work in the United States. In fact, I think it'd actually have like the opposite effect, where it's like another social platform would pop up, like Black Market, sort of thing. It's like, no, this is where you get the real truth. Ironically, I think that is a social platform. So, yeah, so I don't know, like, we'd be arguing with less people, maybe. I think, maybe not.
Maybe
I don't know. Like, does Huberman get to talk? Because like he says dumb stuff all the time. Does Rhonda Patrick get to talk? She says dumb stuff all the time. Like, we could go down the list. Like we were just this morning. This misinterpretation of a mouse study that these people with large platforms are just promoting, and it's like they have credentials, but are just not smart. So
I think I almost sent you most recently. I think Huberman's last episode had something to do with like his expert commentary on the lymphatic system and how to improve your lymphatic system's health. And I'm like, bro,
wow,
you're like a neuro-ophthalmology PhD. What are you doing?
Yeah, look, stuff about the optic tract in rodent models. Like,
respect, defer to all your expertise on that. I know nothing about that.
Pretty much anything else outside of that, like, I would probably just stay quiet. All right, last topic. We're talking about protein powder and lead. Obviously, there's been recent headlines with the Consumer Reports article that's gone viral that found that a lot of protein powders have significant amounts of lead in each serving. Now, it should be noted, lead is this naturally occurring element that's present in our environment. It's in the soil, it's in the water, it's in the air. So virtually all food products, from vegetables to grains and obviously protein powders that made from stuff of the earth, they contain trace amounts of lead. It's an unavoidable part of our food supply, not necessarily an indication of contamination or unsafe practices. And so I just want to clarify that there's got to be some incidental lead in pretty much all food, right? And depending on the soil that the stuff's grown in, right, like vegetables that we consume or should be consuming on a daily basis will actually have a significant amount of lead per serving. But there's also the risk of contamination. And so I think differentiating between those two things, that is a fair sort of thing to do. Incidental lead you really can't get away from, but contamination and high levels of lead, that is a problem. So there are multiple sort of cutoffs here, and that's where I think the real problem with this article came from. So the FDA right now recommends that if you're an infant or child, 2.2 micrograms per day of lead, that's max. If you're a woman who's pregnant, it's 8.8 micrograms per day, and if you're an adult, otherwise 12 micrograms per day. That's daily sort of threshold. And those are based on clinical outcomes. It's far below the threshold still of like where lead toxicity actually occurs, but they're like, you can get this high and you're probably going to be fine. It doesn't mean you go to 12.1 and it's like, oh no, I have heavy metal toxicity, chelate me. Yeah, no, it's not that. The EU has a different sort of threshold, and this is mainly for legal enforcement of stuff on the market. They say you have to have less than 3,000 parts per billion of lead in something that you're putting on the market. So that's their enforceable exposure. But the article didn't use either of those. Those two targets have been around for a while. They used what was in Proposition 65. This was in some legislation that's passed in California in 1986, I believe, that said, look, if you got a food, you got a supplement, whatever, it's on the market, If it's got more than 0.5 micrograms per serving, you gotta warn people about it. Now, this is 1,000 times lower than levels shown to cause no reproductive harm. So this is not a clinically derived like health risk limit like the FDA or the EU, but this is more like right to know labeling.
It reminds me of when I think I first bought some like iron plates for my first garage gym, and they came with stickers on it, the standard California stickers that said this may contain substances known to cause cancer by the state of California. It's like that type of
exactly.
legislation leading to that public messaging. And so, yeah, just way more conservative, I guess, kind of cutoffs here, way lower than they would need to be to ascertain actual risk of harm in humans.
Yeah. To me, like the FDA limits and the EU's exposure limit, like those two things they're still very low, to be clear. Mm-hmm. But I also think they're reasonable because if you raise them higher, now you're getting closer to the threshold where clinical badness can occur. Prop 65, to me, I'm like, if this label is everywhere, then how useful is it? Right. Yeah. People just, they get desensitized. They're like, well, okay, everything could potentially cause cancer, I guess, whatever. Mm-hmm. Yeah. So as far as how does this apply to supplements? Well, look, some supplements are contaminated. And I think the article does a reasonable job at highlighting some of the unregulated supplements, some from very popular manufacturers that do actually have a decent amount of lead in every serving or other heavy metals. And so I think it's reasonable to avoid those. Like, look, if your supplement, right, is not third-party tested, already I have concerns about contamination. And with respect to lead specifically, plant-based proteins, because that's where you're getting the protein from, that accumulates more lead, so more incidental lead already. And then if it's not third-party tested, right, for this stuff, batch tested, by the way, not just like once a year, I suspect that risk gets even higher. And so you have somebody who's maybe taking a very popular, but I'm not going to name them, plant-based protein that's got almost 7 micrograms of lead per serving. They take 2 scoops a day. Well, now you're at 14.
Yeah.
I don't like that.
Yep.
And just by comparison, WheyRx, our protein, has 0.823 micrograms of lead per serving. It's less than spinach. All right. I'm not saying our whey protein is a better vegetable source than spinach, but as far as whey proteins go, we definitely have one of the lowest lead content. It's just the incidental stuff. You can't get away from it. And we're at 31 parts per billion. So we're way under both of these targets. So look, we're third-party tested. Every batch is third-party tested. If you need a protein supplement and you're good with whey, I would recommend our whey protein. There are other whey proteins and other non-whey protein supplements that also fit this, but just make sure that they're manufactured in a GMP accredited facility. They're third-party tested, batch tested, not just once a year. And you can ask these manufacturers for their laboratory analysis. We were recently asked for ours, and we provided it. Generally, manufacturers are happy to do so, especially if they have good results. But if they're not testing their stuff, don't buy their stuff. Mm-hmm. Like, it's not worth saving a few bucks. People are like, oh, look, I can go to some big box, commercial store and I can get 100 pounds. They send me a vat of protein and it's this expensive. It's so cheap. Look, I'm saving all this money. I'm like, yeah, but it's probably not worth, like, again, it's not that big of savings for this potential risk from not only just lead, but cadmium, arsenic, et cetera. Like, it's just not worth it to me. I don't know. Does that make sense to you?
Yeah, I agree. I think that we're fortunate to live in a time when toxicity from these things is not terribly common. But if you are buying these supplements with potentially more concentrated sources of them, and if you are using them a lot as a part of your diet, you're going to be at a higher risk compared to somebody who's using either a different product or not using them. So do with that what you will.
There you go. Should we play System of a Down Toxicity to take us out?
Oh, great choice.
Yeah. All right. Well, that is a wrap here on the 5th episode of The Rundown here on the Barbell Medicine Podcast, where we bring modern medicine to strength and conditioning and strength and conditioning to modern medicine. Again, I'm your host, Dr. Jordan Feigenbaum. Special shout out to Dr. Austin Baraki for joining me on the podcast. Before you guys go anywhere, please leave us a 5-star rating and a review. It really helps drive traffic to our podcast so we can keep bringing you all the latest nuance in health and fitness. From everyone here at Barbell Medicine, we'll catch you next week and every week right here on the Barbell Medicine Podcast.